Welcome back, Code Crackers. We are officially kicking off part 35 of our 100-part CPC exam series, and I am so pumped for this one. Today, we're tackling some of the absolute most heavily tested and honestly rule-dense areas in the CPT manual. We're talking the female genital system and maternity care. There is a ton of ground to cover here, so before we jump in, make sure to like, share, and subscribe to Decode Healthcare with Harshal. Let's do this.
Okay, here is our blueprint for today. We're going to run through an overview of the female genital system, hit the rules for colposcopies, break down hysterectomy guidelines, tackle the global OB package, look at when you need to split that maternity care, and wrap it all up with a quick summary cheat sheet.
So, let's jump right into Section 1, the female genital system overview.
All right, imagine you're auditing an operative report. Your anatomical sandbox for this specific CPT code range, which is 56405 to 58999, covers the vulva, the vagina, the cervix, uterus, ovaries, and the fallopian tubes. It's kind of like a map, right? You've got to visualize the exact organ your surgeon is operating on first. That is your absolute fastest ticket to finding the correct code family.
Moving right along to Section 2, colposcopy rules and cervical procedures. Think of this as our first little mini-boss of the day.
When you're dealing with cervical procedures, you really have to read that operative report with a magnifying glass. You've got to ask yourself, is this just a simple diagnostic colposcopy, or are we looking at a colposcopy with a biopsy? Maybe it's a major excision, something like a LEEP or a cervical conization. The actual surgical technique changes your code selection completely. And of course, that completely changes the reimbursement too.
Now here's a massive rule of thumb alert, because this is a classic CPC exam trap. Diagnostic endoscopies, like a standard diagnostic colposcopy, are absolutely always bundled into surgical colposcopies if they're in the same anatomic area. Basically, if the surgeon takes a look around and then decides to cut, you only bill for the cutting. Don't fall into the trap of double dipping.
All right, Section 3 brings us to hysterectomy guidelines. Honestly, we are now entering one of the most heavily tested areas on your entire exam. Okay, so the very first step in coding any hysterectomy is isolating the surgeon's exact approach. Did they go through the abdomen? That'd be a total abdominal hysterectomy. Or was it a vaginal approach? Maybe it was laparoscopic, like an LAVH or a total laparoscopic hysterectomy. That single detail completely dictates your code family. But wait, there's more. You also have to hunt for critical modifying factors in the notes. A huge one is uterine weight. You need to know, was it 250 grams or less, or was it greater than 250 grams?
Once you've nailed down the approach and the weight, you have to ask one more critical question. Were the fallopian tubes and ovaries removed too? That's what we call a salpingo-oophorectomy. If the surgeon took the uterus, and the tubes, and the ovaries, you absolutely need the specific code that bundles all of that work together. You can't just use the code for the uterus by itself.
Okay, let's head into Section 4. The global OB package and maternity care. This is the final boss of today's explainer.
The global OB package, which lives in the $59,000 to $59.99 range, is essentially the holy grail for uncomplicated pregnancies. It beautifully bundles all the routine, expected maternity care into just one single code. That literally saves you from having to bill for dozens of individual visits.
So, this global package is broken down into 3 distinct phases. Step 1 is antepartum care. That includes all those standard prenatal visits leading up to the birth. Then, Step 2 is delivery services. This covers admission, managing the labor, and the actual delivery of both the baby and the placenta. Finally, Step 3 is postpartum care, covering routine hospital and office checks for up to 6 weeks post-delivery. Just as an example, code 59400 covers this entire shebang for a vaginal delivery, while 59510 is your go-to for a cesarean.
But of course, things don't always go exactly to plan. That brings us to Section 5, split maternity care, and exactly when you need to unbundle. In the real world, you're going to run into scenarios where you have to unbundle that maternity care. Think about it. What if a patient switches their insurance right in the middle of their pregnancy? Or maybe they relocate to a totally new state? Or they might receive care from multiple completely unrelated medical practices. When any of that happens, the continuous timeline of care just breaks. In those specific cases, you can't use the global code anymore. You have to split the OB package and bill those individual phases, like just the antepartum care or just the postpartum care, totally separately.
To really put that into perspective, let's compare. A global OB code like 59400 covers that entire start-to-finish timeline. But let's say an exam scenario tells you a patient moved into town at 39 weeks and a new doctor only performed a cesarean without doing any of the prior prenatal care. In that case, you'd jump straight to a delivery-only code, like 59514. The specific wording of the scenario totally dictates whether you build a global package or you split it up.
All right, let's wrap this up with Section 6, our summary cheat sheet with the golden rules.
Get ready to lock these in for the exam. Rule number 1, always bundle diagnostic scopes into surgical ones. Number 2, map out every single hysterectomy by surgical approach, the uterine weight, and whether the tubes or ovaries were removed. Number 3, global OB equals antepartum plus delivery plus postpartum. And finally, number 4, only split those OB codes when the care timeline breaks due to things like insurance changes, a relocation, or using different providers.
And that wraps up Part 35. Coming up next in our explainer for Part 36, we're going to tackle endocrine and nervous system CPT coding. We'll be breaking down thyroidectomies, spinal injections, and cranial procedures. But before you go, ask yourself this. If a patient switches insurance at 38 weeks, are you 100% confident in how you'd split that OB package on tomorrow's exam? Really think that over. Make sure to like, share, and subscribe to Decode Healthcare with Harshal, and I will catch you in the next one.